Hello, everybody. This is Dr. Becker. Welcome to week 13. This video is for our nurse practitioner students. Excuse me. And today we're going to visit a little bit about what it means to be specifically an acute care nurse practitioner. And for you guys, of course, obviously, it's the adult gerontological acute care role. I think it's really important to have a little bit of an understanding of the history of the role, how it's come to be what it is today, so that you can have that appreciation of how your role has developed. And then that can also help us lead into the future direction of the acute care NP role. It's also important to talk about the specifics of some of the competencies that maybe are a bit worded differently or have some specific nuances to being an acute care NP. And so as we're tying in leadership and direct clinical practice and guiding and coaching and collaborating, etc., it is important that we bundle this all together as it will pertain to you guys as acute care NPs. The acute care nurse practitioner obviously diagnose and manage diseases. We also promote health of the adult patients with acute, critical, and complex chronic health conditions and injuries. Oftentimes, the patients may be physiologically unstable, technologically dependent, or highly vulnerable for complications. I think is kind of a unique way to say this. We provide comprehensive care in a collaborative model with the physicians, nurses, other providers, patients, and families. And we apply unique knowledge and skills in caring for a very complex and vulnerable patient population. Important to point out that the adult gerontologic acute care NP incorporates the entire spectrum of adults, including the young, middle-aged, and older adults. So when you do get into your clinicals next semester, you'll be able to see patients 13 and older again, as you know from this time in health assessment as well. Most acute care nurse practitioners practice in acute and critical care settings, but that can also include subacute care, so rehab, long-term care, emergency room, inpatient units, ICUs. And then within those settings, so sometimes it's outpatient, sometimes it's inpatient, but as an acute care NP, you can provide care for patients with wide ranges of specialties, but some of those could be acute and critical care, neurology, pulmonary, nephrology, trauma, transplant, PACU, pain management, cardiac, palliative care, etc. And then also to point out that in recent years, the adult acute care competencies were revised to reflect the evolved focus of acute care of the adult and older adult. And that became around in 2012. So the adult gerontological is now the AG-ACNP. Back when I was in school, and I graduated 2009, my certification is acute care NP. The word gerontological does not show in my certification at all. And the way they did that now is I'm grandfathered in. So long as I don't have my license lapse, I would not have to sit for a new test. So for the rest of my career, as long as I maintain an active license, I'll always be an acute care NP. But I'm grandfathered in and I can take care, obviously, of gerontological children. Also, just be careful that acute care NP could also refer to a pediatric. So those are referred to as ACPNP, acute care pediatric nurse practitioner, and the AGACNP is the adult gerontological acute role that y'all are in. So the emergence of the adult, the AG-ACNP role evolved as a result of changes in the delivery of the healthcare and the healthcare system overall. Excuse me. So one of the biggest things that came about for it was that there was a change in how residents were used. So they used to be able to work residents really, really hard. I mean, some of these medical resident students were working 140 hours a week. They were on for 36 hours, off for 8, on for 36. I mean, truly ridiculous things. And so that has been really, really reduced. And for the most part, in my experience, it's an 80-hour work week for the resident, which is still a lot. But it's cut back. So what that did was it created a void that really has been filled by acute care NPs. For my example that I know, I did work in adult trauma and adult surgical ICU. And one of the main ways that they utilized us was one, truthfully, and I mean this with all respect, we were babysitters for the residents when the trauma surgeons were in the OR are not available. But then they also used us to fill in the gaps. So if it was a weekend without resident coverage, the acute care NPs filled in that gap. So it very much was created to answer the call of what was needed. Also, there's been a shortage of intensivist physicians, so acute care NPs have also been called to fill that void. But by the late 1980s, nurse practitioners were increasingly used then in tertiary care centers and large major medical facilities. But in 1995 was when there was actually a recognition to be certified as an adult acute care practitioner. The competencies of the AG, ACNP role, obviously we do follow the competencies of all APRNs, and then each different role, whether it's an NP, CNS, midwife, etc., has their own kind of standardized language or their own standards within those competencies. Maybe they expand on them a little bit more, but there will be things that are unique to what you do as an ACNP. Again, the central competency is always going to be that direct clinical practice. But also just to point out, as we all obviously know, you're providing care to adults who are at risk for physiologic instability. And I'm not sure that, honestly, to tell you my opinion, I'm not sure that even that, excuse me, is the greatest definition of this, because how does that separate from you taking care of a 90-year-old in primary care, right? People are living longer with a lot more illnesses, and therefore when you're 90 and you've got 6 big diagnoses, you're complicated and you're definitely at risk for physiologic instability. So that is kind of interesting language to me, in my personal opinion, but it does really show that we're really trying to work for people that are complex, or not work for, take care of people that are complex or are really at risk for having bad outcomes or physiologic instability. It's really important that we understand the outpatient versus inpatient idea, especially in today's healthcare system. We used to just say, like, acute care NP should be inpatient, outpatient should be family practice. But that is not the case anymore. As you guys know, there are people that are in outpatient rehabs that are definitely chronically ill and complex, or LTACs. It's really hard now to define whether an acute care or family practice should be inpatient or outpatient. So we're not looking at the actual location that they're in. It's the population of people they're caring for. So you can be in an urgent care, an acute care, a rehab, all of those things to use your skills taking care of patients who are at risk for physiologic instability. Again, you have factors in common with all the other NP subspecialties. So we all have that generalist nursing foundation. You all are sharing that you're bachelor's prepared nurses that went on to receive at least a master's. Everybody still has health promotion as a basis to their practice. Everybody undergoes the development and understanding of the diagnostic reasoning and skills. So those are all things that are similar across the board. In the reading, I wanted to point out box 14.1 there did show the standards of clinical practice and professional performance for the expert acute care NP. And so there's where advanced assessment, differential diagnosis, outcomes identification, care planning and management, implementation, evaluation. Those were the standards of clinical practice. For professional, it was professional practice, education, collaboration, ethics, systems and organizational thinking, resource utilization, which is evidence-based practice, leadership, collegiality and collaboration, quality, and clinical and practical inquiry. And again, when we start talking about what are some of the nuances that are specific to an acute care NP, Again, we still share everybody as an APRN has their direct clinical practice as their primary competency. And what's interesting again is that when you compare midwife, CRNA, CNS, or NP, NPs, we function the most within this direct clinical practice competency than any of the other APRNs. And the goals of the ACNP include patient stabilization, minimizing or preventing complications, attending to all of the other comorbidities, and then the promotion of their physical and psychological well-being. They also talked about in your reading the additional goals include the restoration of maximum age-specific physiologic and psychological health potential, also palliative and supportive and end-of-life care. So as an ACNP, you'll achieve these goals through performing cognitive skills such as your advanced assessment, clinical and diagnostic reasoning, critical thinking, case management, and then prescription of therapeutic interventions. Assessing, prioritizing, intervening in complex, urgent, or emergent situations are key components of the ACNP specialty competencies. The central competencies of direct clinical practice as they apply to you as an ACNP can be broadly characterized as those related to the diagnosis and management of disease, which is what can be specific to where we really function more than the other APRN roles. Box 14.2 in your reading, if you have those pages open, is interesting because it talks about the adult gerontological acute care NP list of top work activities arranged by criticality. So 1 is interesting because their number 1, arranged by how critical it is maintaining HIPAA. Okay. But number 2, urgent and emergent conditions and assessments, rapid changes, know the differentiation between normal and abnormal findings, and so on and so forth. So that's kind of an interesting reading as well. Table 14.1 in your reading shows the top 25 diagnoses most frequently managed by acute care nurse practitioners, which is very interesting. You know, it's obviously hypertension, heart failure, upper respiratory illness, GERD, heartburn, UTI, CAD, etc. I just wanted to point out on here, there's also back pain, dizziness, vertigo, headache, depression, allergies, sinusitis, etc. So obviously as ACNPs, we see a wide variety of things. The other thing that's more unique to us versus some of the primary care nurse practitioner roles is that there's the performance of patient procedures, which we have spoken of briefly in earlier lectures about. That used to mainly be only in the purview of physicians, and we have started expanding into the procedure world of things. And you will learn in your upcoming diagnosis and management the critical care kind of procedures. You're going to learn intubation, thoracentesis, paracentesis, central line placement, art line placement, suturing, casting, splinting, incision and drainage, and lumbar puncture are some of those main procedures that we will teach you when you do get to your immersion courses, which is really exciting. Everybody likes that part. And obviously that's part of direct clinical practice. The direct clinical, or excuse me, the most common procedures performed are also listed in your reading. And those were things that they considered to be procedures, as you guys have learned with your health assessment this year, is that it's even in interpreting radiology studies, doing vasoactive IV drips, resuscitative efforts, wound care sutures, incisions, ventilation, etc. So those are all things that are considered procedures that you will be able to do. They also could include things like nerve block, needle thoracotomy, chest tube insertion and removal, cricothyrotomy for the trauma, needle aspiration. There's a lot of different things. And a lot of those you may learn and be credentialed to do based on whatever role you are doing. So our direct clinical practice as a competency is very broad and includes a lot of things. And it also includes these procedures and skills that you'll be learning as well. And also it's important to remember that some of the things that you will be able to do that's in your direct clinical practice is going to be things that are how to use the tools of healthcare that you'll be trained in that not everybody in the NP role would be. And in your reading, it talks about the publication Integrating Adult Acute Care Skills and Procedures into Nurse Practitioner Curricula from NOMP that was released in 2011. Talks about we should always make sure we're teaching intracranial pressure, 12-lead interpretation, defibrillation and cardioversion, pacemaker, hemodynamic monitoring, arterial punctures, chest x-ray interpretation, et cetera, even how to do pulmonary function assessments, spirometry and peak flow, local anesthesia, those things. And I like this. It says that the increasing acceptance of these invasive procedural skills is within the scope of practice for you as an acute care NP, and it is supported by evidence that the complication rates are no greater than those of physician providers, as well as increase in employment of you guys in critical care. And now we're seeing improved third-party payment for the APRN performed procedures. So it's been around now over 10 years that people have been paying for this. Yes, becoming very commonplace. And so you guys, I'm hoping as you go out into practice, you're not going to hit some of the resistance that those of us that are old now did when we first got into practice, even those of us 10 years ago. So that's exciting to think about there too. And they do go into quite a bit in your reading. Promoting and protecting health and preventing disease. And again, I know we get excited about being in the acute care realm, but just last week when we talked about the guidance and coaching, you still take your holistic nursing with you. And so we are still worried about the promotion of health and prevention of disease. So inevitably, the methods that you may use could be very different from those in primary care specialties, because obviously we're always going to prioritize immediate health needs over like the recovery of chronic health. But that is always going to be integrated into what you're doing. And it could be a little bit more difficult, like we talked about last week, as an acute care NP, because you're limited to a crisis situation and you don't have that long-standing relationship that many will develop in primary care. From the text here, because I really like the way that they have worded this. So as direct care providers, the acute care NP has the ability to activate strategies and systems to implement primary, secondary, or tertiary prevention initiatives. For example, some risk factors imposed by an inpatient stay are physiologic in nature, some as immobility, decreased nutrition, fluid and electrolyte imbalances, altered immunocompetency, impaired self-care ability, existing or developing comorbid disease states, and risks associated with invasive diagnostic and therapeutic interventions. But other risks have a psychological foundation, such as alterations in the patient's physical abilities and their environment, sleep deprivation, communication impairment, alteration of self-image, role reversal, financial challenges, knowledge deficits, and the consequences of medication administration, including but not limited to delirium and depression. Families are also influenced by many of these risks and require ACNP services. Acute care NPs must often lead difficult conversations with patients and families regarding crisis situations, terminal diagnoses, or deleterious effects of chronic diseases. Skillfully navigating conversations regarding goals and expectations of care and care wishes at the end of life can be a daunting task for even experienced acute care clinicians. So again, the nursing and the holistic care attitude that you have will carry with you. And even though we aren't in primary care, maybe we don't have the benefit of longevity with a patient, we still are very much involved in the overall health promotion part of it. As far as guidance and coaching, patient care will involve many different individuals as listed here. And the explanation of the process of care while educating others about the disease process means that the guidance and coaching, just because you're not in a long-term relationship with the patient like you would be in primary care, you still have guidance and coaching even in the acute care arena. And remember, the guidance and coaching can be patient, families, and the other healthcare providers. Advancing knowledge of providers through mentorship, coaching, and education delivery is still essential to improving care outcomes in both your or in the acute care population. And again, where you will shine as an acute care NP will be your ability to be adept at communication with patients and families in time. Absolutely. Let's see. Frequently informal exchanges regarding patient condition and plan of care, consultation, collaboration. We've talked a little bit about that. Obviously, quite a bit will be involved in that as well when you function as an ACNP. Evidence-based practice. We, as acute care nurse practitioners, very much are involved in evidence-based practice, and we also contribute to the development and the application of EBP to improve the care delivery. For ACNPs to achieve the competencies to diagnose and manage disease within our population, we have to demonstrate mastery of advanced pathophysiology. We have to know advanced health assessment and advanced pharmacology. We have to have an understanding of the normal physiologic changes of aging and therefore recognize our abnormal variations and the age-related implications of safe interventions and pharmacology. Evidence-based care is a competency that's essential to us as an ACNP, but it could look very differently, again, than some of the other NP roles. All ACNPs draw from the literature to deliver evidence-based medical and nursing care and actively participate in EBP quality improvement initiatives. Acute care NPs have been instrumental in adopting and leading initiatives for implementation of practice standards and guidelines. And especially those who are ACNPs that are prepared at the doctorate level often will be at the lead of these initiatives as well. You will serve as a leader and a participant in EBP, and a leader in both the generation of new knowledge and the translation of evidence to improve clinical practice and patient outcomes. Leadership, again, we've talked ad nauseum about leadership in your leadership class. But you're going to be serving as mentors and role models for staff nurses. Very much will be in your purview as being an ACNP. You'll function as a leader in overseeing and coordinating and directing delivery of comprehensive clinical services within and across the healthcare system. Absolutely. The acute care NP promotes a positive healing environment and demonstrates assertiveness and conflict negotiation skills. Providing leadership in the planning and implementation of system-wide initiatives is also an aspect of what you'll likely be doing. Some of you may even function as a leadership responsibility, maybe at some point in your career for a group of ACNPs. That could be a possibility. And again, we've talked about clinical leadership already, and the nurse practitioner as the acute care NP definitely functions in this role, oftentimes within an ICU setting especially. And again, understanding the relationship between the policy and practice is those things that you guys have talked about with Dr. Waltman thus far, and it still holds true to the ACNP role. Collaboration is very, very, very huge in our role. Even though in most states we can function as licensed and independent practitioners, oftentimes as an ACNP, what also separates us from the primary care ideal role is that we do function within a team. You don't hear about many ACNPs going out and opening our own hospital that's free of physicians. That's just not the way that we work. In the majority of ways that we work definitely in collaboration with the medical field and the specialists. And again, I like this. The advantage is ongoing continuity and coordination of care. So collaboration is huge. You're going to collaborate with everybody, the physicians, the therapists, the pharmacists, all of the above. We will also have, of course, ethical decision-making. And I would argue that oftentimes ours can be a bit more intense because we tend to find ourselves in more critical care or intensive situations with end of life things, more so than maybe our counterparts in primary care. So your scope of practice as an acute care NP will be shaped at these 5 different levels, obviously national, state, local, your service related or your role that you're in within a healthcare system, and then you individually, what your comfort is. So all of those things shape what you end up defining as your scope of practice. When we talk about the national levels, there's the AACN scope and standards for acute care nurse practitioner practice. Was initially developed jointly by the American Nurses Association and the AACN originally in 1995, and then the American Association of Critical Care Nurses in 2021 updated it again. And it goes into very much the same things we've already spoken of. What I wanted to point out, and you saw this in your reading, is that this was great because the updates in 2021 specifically says that for us to be considered acute care NPs, we also can function, and our population does expand to include the mobile environment and virtual locations such as the tele-ICU and areas that use telemedicine. And this is important because when COVID happened and all these things have happened, there was very much some question about whether or not, by definition, we could be acute care NPs and be in the telemedicine arena. And they very much lined this up in 2021 and outlined this specifically. So what they say is that these standards of telemedicine are closely aligned with the APRN core competencies because they describe a competent level of care common to all ACNPs regardless of setting, whereby the quality of expert ACNP practice can be judged. So that's a huge deal, and those are why things at the national level for us are so very important to have good policy and to have these arenas where people are supporting us is for this very reason, is that we were kind of, for those of us in the acute care arena, there was some question about how could you possibly function in a critical care role and be online or some kind of telemedicine. So that was great that we had that support and their validation that we absolutely could. The AACN and the NOMF collaborated to define the minimum competencies necessary for safe entry into the ACNP role in 2013, updated it again in 2016. And then there are resources that do not define your scope of practice, but do specify the knowledge and skills that are necessary to perform within your scope at the ACNP National Certification Exams. The APRN specialty certification serves as the primary criteria for APRN practice, and in addition, Medicare regulations stipulate completion of national certification as a requirement for ACNPs to obtain reimbursement. So your ACNP certification exams can be offered by the American Nurses Credentialing Center, so we have ANCC, or you can choose to be certified through the American Association of Critical Care Nurses. The topics and content for the ACNP, the acute care certification exams, have been validated and are consistent with the other documents delineating the ACNP scope and practice. Stay up there one. Again, your entry to practice competencies, like we're talking about, are listed here. When we talk about state level, right, the nurse practice statute for each state governs your nursing practice. You guys are already familiar with this in the RN role that we follow. If you're practicing in South Dakota, the South Dakota State Board of Nursing. If you're in West Virginia, you're under the West Virginia State Board of Nursing, and that continues on as an APRN. In all states, APRN regulation for practice is based on basic nursing licensure, but many states have additional rules and regulations that delineate specific requirements and define and limit who can use what specific advanced practice title with protection. And actually, I'm new to South Dakota in the last 2 years, and I can't believe I haven't looked this up yet, but in Wyoming, specifically in our state statute from where I came from, there was a very clear clause that said I would not be able to introduce myself as Dr. Becker to patients because it was confusing for the healthcare population. And so nurse practitioners at the doctorate level or any nurse with a PhD or doctorate was not allowed to refer themselves to a patient as a doctor within a hospital setting was outlined in there. So I actually have not looked that up in state, but that's an example of what could be different state by state. And we will talk about that, some other state things, I think, in another week lecture. But over, I'd say the last, since about 2012, all the states have really harnessed in on saying that they're taking a stronger stance to ensure that the NP scope of practice at state level is defined in ways consistent within the APRN consensus model, and they're particularly taking an active role in the differentiation between primary and acute care. This happened locally at the state level in Sioux Falls and, South Dakota. And when they came out and they said that they were going to support that you had to be practicing within your population of focus, and that the FNP being in an acute care environment might likely be outside their population of focus. And that causes a lot of ruffles because you have people that have been an NP for 15 years as a family nurse practitioner functioning in an ICU. And their argument always was, what good would it do for me to go back to school per se, et cetera, et cetera. So your scope of practice is defined within your state level. And that's really important that you do understand your state regulations. And again, remember, as you do move across state to state, if you start doing telework or you do locums work or what have you, please be aware that whatever state you're in, you are held to those standards of practice there. Next, we talk a little bit about the institutional level. Again, at each institution, they can further delineate your scope of practice by identifying the patients you serve, and how you will collaborate with other healthcare providers in the institute. So again, scope of employment may not exceed your scope of practice, but your scope of practice may exceed your scope of employment. What do we mean by that? So you may have the state of South Dakota fully saying you are able to do intubation, you are able to do chest tubes, and you are able to do central lines. They recognize that for us. But you may go to a facility, ABC hospital in the middle of nowhere, and they may look at you and say, your scope of employment within our institution, we do not allow ACMPs to do those things. And you're stuck with that. Just because your national level or your state level tells you that you should be able to do it, we recognize that you can do it. You may have the education and the transcript saying you've been trained on doing it. It doesn't matter because your scope of employment will be what limits you. But they also cannot ask you to do things that exceed your scope of practice by your state nursing board, right? So that's why knowing your state board scope is very important. Sometimes you'll see specifics in your job description, your hospital policy, or even both. And so what does that look like? There are rules that are going to happen that maybe you work within an institution that tells you all of your all orders, no matter what, have to be co-signed by a physician. And even though you can come at your institute and say, nope, my state scope of practice says I'm a licensed independent, I don't need that. Again, you're within the institution's rules and regulations, and you could be restrained, if you will, by that. That is the way that works. I've worked in facilities as an acute care NP when I was the first one ever at their hospital. That told me I couldn't be in the ICU, that the hospital does not allow a nurse practitioner to write any orders on an ICU patient. And that took a lot of time to get that changed. Also remember, or maybe you guys are learning this for the first time, when you undergo credentialing and privileging, that's at an institution level, right? So what does that mean? That means you have to apply for privileges and credentialed, meaning when you get hired onto a facility for your first job as an APRN, as an acute care APRN, you're going to apply for privileges. So I do this all the time. And in my current job, we do this every couple of years. You reapply for privileges. So you go in and I say, I want to be able to be privileged and credentialed to do an H&P, order medicine, yada, yada. It's a whole list of things. It's your basic, all the things you do as an NP. And then I say, I want to be able to do local anesthetics, incision and drainage. Do I want to be able to do PICC line, art line, central line, what have you? And you have to be privileged and credentialed for each of those things. And sometimes these are 5-page documents and they're very specific. Like you have to be credentialed and privileged. You have to have privileges to do interosseous placement in my facility. You have to be credentialed to be able to do stress test reading. So if you do role change, so for example, when I was working as a hospitalist within the institution, and then I took on the role also of cardiology, and I had to apply for privileges to do stress tests. And so somebody at that institution is protecting their patients by saying, before Sarah can do stress tests, we need to verify and validate that she is competent and able to do that. And so I had to do that. So for them, I showed them my classes that I had done and all those things that I had done for education. And so for the first 3 months, I had temporary privileges, and each of my stress tests had to be for like 12. It was some random number. I had to have signed off by the cardiologist with me that I did 12 witnessed. And then I had a month of time that they had to review all of them, and he had to compare my interpretation without him to his interpretation, and he had to sign off on all of those. So there was a step-by-step process, and then I was fully credentialed and I could do those independently. So this is weird sometimes because when you're a nurse, oftentimes you just go in and you expect you can do all the nursing things. And especially as an acute care and a health institute, you're going to have to say, I can do this or I can do that, and apply for those privileges. And sometimes there are hoops that you have to jump through to do that. If you say I did it at my job before, they're going to request that you get those records from the credentialing office there, that they are able to pull that and say, yes, Sarah did 350 stress tests in this calendar year as we verified, and she billed for that. And they could send that off to your new institution to verify you have those privileges there. So credentialing and privileging is at the institutional level. It doesn't matter if your state says, yes, you can do them. If the institution says no, you're stuck there. But if your state says you cannot do something and the institution tries to say, yes, you can, you have to follow your state. So your state trumps your institution in that way. And then sometimes you apply for credentials and then privileges maybe. When you're credentialed, that means you've gone through all the billing and the verification of your licensure and all those things. So to receive your credentials to practice. So not every nurse practitioner can walk into a hospital and start writing orders. You have to have credentials and privileges. You are allowed to practice there, which is why sometimes you get into politics of medicine in that if you have your credentials or your privileges removed, that's obviously a huge deal because now you're not allowed to practice where you're employed. So that's an issue. And then you have next here your service related level. So how you function as an ACMP may be adjusted according to the needs of the specialty population served in your delivery system or your service line, for example. So an acute care NP working with cardiology, you're likely going to be able to initiate treatment for an MI. Whereas if you're a pulmonary ACMP, you may be able to order vasodilator therapy. When I worked in oncology, we were able to perform bone marrow aspirations, whereas I wasn't going to apply for that if I was a cardiology NP. So there are service-related things that you will have as part of your scope of practice. And so they can be varied. And as an NP, we tend to be able to do the things like a lot more invasive procedures than the primary care world can. The other thing that we have to talk a little bit about, especially in the acute care NP realm, although many states no longer require a formal or written collaborative agreement, there can be situations in which the healthcare organization or the service line that you work for will have collaborative guidelines. So your institution and your service line may have things in your scope of practice that could be determined collaboratively by the physician and the acute care NP and set forth in a written agreement. So the written agreement for your collaborative practice then provides the source document on which the hospital makes privileging decisions. So written agreements are often formulated as the checklists, and they can be helpful because the detail included in the written agreement cannot be spelled out in a job description. So the agreement might also specify the level of communication or the degree of supervision between the ACNP and the physician that is required before the performance of a specific function. For example, an ACNP with novice skills in central line insertion may require direct supervision for a specified period of time or number of successful attempts. But when you approach expert status, the level of supervision may be decreased to minimal or none. Eventually, as the ACNP expertise continues to advance, they may supervise medical trainees or other novice ACNP in the skills. As the skills progress, the written agreement, if required, will also need to be modified. In some cases, the written agreement may be used to communicate the acute care NP scope of employment to other members of the healthcare team. And again, when you are in practice, if you find yourself negotiating some kind of written collaborative agreement, you are the one that is responsible to ensure that no function conflicts with your state practice act or your institutional policy, right? So sometimes these things get a little messy and trying to navigate to make sure everybody's happy with what you're coming up with. So the agreement should not be a barrier to practice, but be written as broadly as reasonable to allow for practicality, flexibility, and optimization of practice within the context of experience and safety. Many times, like in an ICU setting, there's going to be some kind of realm where there is, there's going to be some kind of understanding that if you are there as an acute care NP, you're practicing under the attending provider, et cetera, or report to, or that they can outrank you, so to speak. So if I write orders, if I round and I do things as an acute care NP and I'm working with cardiology and my cardiologist came behind, he could change my orders and be within the realm because he was the attending. He was actually the cardiologist. You may have heard the term physician extender. I've seen some job descriptions written that way, meaning that you are there as the extension of the physician working with him or her, and that is kind of how you're viewed. So in other words, you are there representing Dr. Smith, right? So if they consulted cardiology and Dr. Smith and I, for example, might be over in clinic and I come over and round on the patient, I am there as an extension of Dr. Smith, for example. This is very common within the acute care environment, and it is an ever-pressing point of difference sometimes when we talk about being a licensed independent practitioner and what does that mean. And you will develop your own thoughts and feelings on this. It's a very hot topic in conversation. And one could argue, how do you define when you're ready to be on your own or not? Or how does that work? An example would be I had a mentor in cardiology, and she had been with the same group in the same practice for 18 years. She was an incredibly intelligent woman. I mean, she was just hardcore, great, wonderful. She was like a sponge. She remembered everything she did. She worked long hours. She was just the bomb. She was excellent. And she had no technical supervision within her practice. Nobody questioned her. She went out there and she did things. She had a wide berth. She functioned very autonomously. Nobody questioned anything that she did. But that was what that privilege to be that independent was something she gained through her years of experience that led into expertise. So her group felt very comfortable with her. But the fact remained that the facility within her where she practiced, the health system, clearly said that she was a physician extender. And so even though she knew more, I would grant you, than some of the fellows of cardiology or the baby cardiologists by far and away, she still was within the acute care NP role and was seen as a physician extender within that service line and within that health institution. And at one point, she did have a collaborative agreement that completely went away when they felt that she reached that expert status. When we talk about individual, you will have individual characteristics that will affect your employment opportunities, your practice arrangements, and the degree of autonomy that you seek. This is really tough because I would argue, and I think most people would agree with me, one of the areas significantly lacking is novice APRNs not necessarily going into a healthcare institution that has any kind of support for the novice person. You know, that year or two where you're mentored or you're seen as novice or you're entered into that phase with that understanding that you're at the novice level and that there's some kind of support in place for you that you graduate from. And so that is really tough. There are many times that you get into practice and people that are employing you, they don't understand what that means, anything. They just expect that if they're hiring an acute care NP, they are hiring someone who could walk in on day one and do central lines and intubation and what have you. So part of you seeking employment is making sure that you advocate for yourself to say, I will be coming into practice as a novice APRN. In school, I will have learned and been taught the skills of the procedures that you have outlined in your job. However, I would need training and some probable support and credentialing process on how to do that. On-the-job training is going to be needed. And so you are encouraged to engage, this is what they're saying, in that self-reflection and performance appraisal in order to continually assess and improve your knowledge and skills. So you as an ACNP fresh to practice, when you're going from novice to expert, you have to be aware of patient situations that can exceed your current skill. You have to know and be willing to seek advice, assistance, or consultation because you are responsible for your patient's safety. And I would argue that this is something that's more intense, if you will, for an acute care NP in practice sometimes than that of maybe a primary care NP. There's a lot of different ways that you may be functioning. There's different practice models is what this is talking about. So episodic management of patients in a single specialty unit. This is what the original ACNP practice model was based off of, and the managed care of a patient with acutely unstable medical or surgical position until they're stabilized. Once the patient's stabilized, the patient would be transferred to another clinical unit under the care of a different provider. And so you're very episodic. The limitation is that it does not allow for continuity of care across the continuum. Or you could be where you follow a caseload of hospitalized patients throughout hospitalization, which is nice because it can provide that individualized ongoing care and provide some continuity to patient and family. An example that I felt worked very well with this was when I was in trauma. So we would meet, we responded to the traumas, we were in the trauma bay, we helped run the trauma, and then we would be part of their team when they were being cared for in the ICU, or, assuming they were critically ill. And then as they recovered and into rehab and those things, the NPs, as we functioned, we were that continuity. And so we would have our own caseload of patients that we also followed in the outpatient realm. And so it was really neat to meet somebody in a trauma and then 8 months, 12 months later, follow up with them again and see their recovery and the understanding, and also be that continuity for the patient. So some of those can allow you to follow that caseload of patients throughout their continuum under your service. Sometimes it's just episodic. So there are times when you are just in the ICU, and when they leave the ICU and go back to the medical floor, you don't follow them. Sometimes hospitalist NPs, for example, you would follow them wherever they go. And then there are people in some communities that still do outpatient things. So, like if I was in cardiology, I saw them in the clinic, I would be consulted and see them in the hospital, and then I would follow them after discharge back in the clinic. So I functioned in both of these ways that you could manage them across the entire continuum from hospitalization to home and back. And this is something that you'll realize which one you prefer, and maybe find employment that gears you more towards the one or the other. To me, they both have their positives and negatives, and it really depends on what you consider to be important to you. All right, this is really important. The comparison with other APN and PA roles. So how do we as acute care NPs differ from other APRN roles? So let's start with that. Obviously, I've said it 12 times. We differ because of the population of people that we are able to care for. APRN or the ACNP differ, obviously, because of that, the acuity of the patient's condition, the need for rapid or continuous assessment, etc. An example they gave in the book is that the CNS enacts the APRN role through the three spheres of influence, but in comparison, the ACNP uses clinical assessment skills to assess complex and acutely ill patients all the way through. So both of those roles target a patient-centered approach, but the continuous on-unit presence of the ACNP at the bedside often differentiates that role of the ACNP from the CNS. However, although institutional variations in roles for the CNSs and ACNPs sometimes can very much lack a clear-cut differentiation, it is acknowledged that the CNS and the NP roles are different with distinct practice foci. The example they give in your book was with diabetes care, for example, the acute care NP practice predominantly involves strategies directed towards management of the patient during an exacerbation of the diabetes. For example, they'd be admitted to the hospital, they're monitored, they may have different management strategies. Maybe you're on every hour glucose monitoring, etc. They may have an infected foot ulcer that needs IV antibiotics, etc. But once the crisis is over, while still being hospitalized, the acute care NP may provide discharge teaching on the diabetes and the foot care and the glucose monitoring. And at this point, the patient may be referred back to their primary care. In comparison, the primary care is predominantly directed towards the management of the patient's diabetes when it's stable, right? So the ongoing surveillance, guiding, and coaching of the patient's self-management of the diabetes is more the focus of the primary care NP. At the point when the patient's not responding or becomes acutely ill, the primary NP will recognize the need for the patient to be referred to a setting in which continuous monitoring and management are provided, and therefore back to the acute care NP. So that is also an example. You're going to hear all the time, how are you different than a physician assistant? Or don't you do the same thing as a physician assistant? Okay, so ACNPs are different from a PA because the PA role is under the jurisdiction of the physician's license. So some overlap exists between what we do as acute care NPs and PAs in terms of the management of disease, but the acute care NPs practice competencies, right? So our leadership, our guidance, our coaching, etc., and our holistic nursing perspective is where we can stand apart. PAs are trained in the medical model to focus on providing illness-based care to patients. Nurse practitioners, especially acute care with our nursing background and practice, we will bring a wider range of expertise in patient and family education, communication, collaboration, and health promotion for the individual and their family. So a growing number of facilities are integrating PA and acute care practitioners on hospital-based teams to manage care for the hospitalized patient. Then we talk about ACNPs and physician hospitalists or being on the hospitalist team. A primary care physician refers a patient to the hospitalist team for management during their acute care admission. So far and away, I'd say over 95% of the time, the primary care does not come to the hospital, and the hospitalist team provides the care. The goal of the service then is to provide seamless, cost-effective care and can be advantageous for the primary care with busy office hours, etc. The specific role as an acute care NP as the member of the hospitalist team is similar to the roles we've already talked about. You'll do H&Ps, physical exams, make rounds, develop a treatment plan, review the laboratory studies, etc. You will be part of coordinating patient care management when many consultants are involved in decision making. You'll be often a consult with the hospice and palliative care team or case managers, etc. So acute care NPs in the hospitalist role or the intensivist role is hugely on the rise still and much in demand, and a large function of the acute care job market is within hospitalist or intensivist roles. Uh, this one here, the outcomes related to you as an acute care NP in practice. Measuring the practice outcomes is a component of establishing the value of any APRN role. Positive outcomes of the acute care NP have been demonstrated time and time again. We are effective to have on the team. We are safe and we provide good care. And the emergency room, inpatient, geriatric, cardiovascular, trauma, ICU, oncology, palliative, etc. The demonstrated positive outcomes for us as ACNPs, we also decrease costs. We do help decrease length of stay, decrease ER visits, decrease use of lab tests, time saving for the house physicians. All of our outcomes compared with physician practices and PAs are equal, if not better. And again, the reading that you had did talk about, we do still need to make sure we are monitoring our outcomes because we keep expanding into different areas. And so as we move out into different areas of care, we really need to be able to prove and say we are good at what we do and our outcomes are just as good as those of others. Did want to touch base quickly on this here, that there can be specializations within your ACNP role, and those are listed here. In bigger hospitals, the rapid response team is definitely taken off to having an NP run that role. What I do is palliative care, and so I have my hospice and palliative care nurse practitioner certification through the HPNA. So there are other specializations that you're able to get. I was very close when I was in oncology to get my oncology nurse practitioner certification as well, but I didn't stay in the role long enough to sit for that one. So this may be something that you find yourself really specializing in a specific area, and there are opportunities for you to take other tests and certifications to specialize as an ACNP. When we talk about the future direction of the acute care NP, that is strongly supported across all across all NP national levels of the nurse practitioner. All of the boards support a doctorate of nursing practice as the level of entry to be an NP. When I first was in practice, I heard 2015, everybody was going to have a doctorate to be an NP entry level. And then I heard 2020, and then we heard 2025. I think that there is a good chance at some point this is going to change. When that's going to be and what that's going to look like, we have no ever-loving idea. And I would suspect that there's going to be the grandfathering in for sure. But just to put that out there in the universe, yes, there's a lot of talk, and it is supported by all the national NP organizations that they support DNP as the level of entry to practice. Augustin is working on developing their DNP program as an option. I'm not going to go into this a lot here, but please reach out to me if you think that that is something that is on your radar. I'd be happy to talk to you about that. I'm excited to be part of that planning at Augie. But I did want to throw that out here. Challenges to the ACNP role were also within your reading. One of the challenges that just is still in practice is that not everybody understands the differences between the DNPs. People think that a family nurse practitioner and acute care are all the same thing, or they have no idea that there's differences and they don't understand. And this can be a troublesome thing if you have an administrator who doesn't understand the differences, for example. You also will have some physicians that continue to feel threatened by your role. And so that can be very much a challenge to you to be able to function within your full scope. Misunderstanding or labeling, etc. Again, it talked about it in there that we very much are against being called a physician extender or a mid-level provider because that stems from the misperception that an acute care NP is a replacement or functions just as a resident or a placeholder. Sometimes you're referred to as more than a nurse, but less than a physician. When that's not the case at all, you are completely different. You're not a physician at all. You're not even in the same medical model of physicians. ACNPs can use formal and informal opportunities to educate your environment that you're in. It's going to be something you will encounter. I can almost guarantee it in some way, shape, or form. The other challenges is to make sure that you practice well at your full scope of practice and represent nurse practitioners well. It's going to be challenging at times to even know how to define yourself or know what to do in some of those ways. And you will, again, even run into issues of people not sure how to use you or what it is that you can do or how you're supposed to function. So this is challenging times for the acute care NP because people still don't understand us. We're still a dynamic role. A lot of what we're doing is changing. We're stepping out into different arenas. We're functioning in a whole lot of different ways. And so if people are failing to keep up with us, then they're kind of lost and they're not sure what to do with us, so to speak. One of the other big challenges we have is reimbursement. So as an acute care NP and you're functioning within things, what happens is if you go in and you do an hour-long H&P, and then the cardiologist would come in behind me, and I would present to him of what I saw and what I did and what I've done so far, and then the cardiologist would come in and speak to the patient, kind of wrap it up then, and either confirm or change what I came up with, and we would work in collaboration that way. That is very much within the realm of how a lot of ACNPs function. Well, then what happens is that it became beneficial for the physician to do the billing because the physician could be billed and reimbursed at 100%. And what Medicare and other people decided was, oh, well, because you're not actually a full physician, we were only going to reimburse you 85% of what the physician did. Well, what happens then is it doesn't take very long for an institution to realize, well, we want the physicians to bill. So the physician has to come in and oversee you because, 100% of $1,000 is $1,000 and 85% of $1,000 is $850. And if you do that times 300 patients in a year, that's a lot of cash we leave at the table. Well, that is a hard thing because now you've created this perpetual system where we have to be overseen by the physician, etc. And again, there's times that this is completely appropriate because the cardiologist of 20 years should come in and give their opinion, and I'm working with him and in collaboration with him or her. So it's a very kind of complicated thing, but definitely the reimbursement things is tricky because it depends on how you were able to bill. There were times we billed incident to the physician. Excuse me. Bless me. And that got really messy, and it was hard for everybody to understand how that worked. So obtaining reimbursement for services is a universal challenge for the acute care NP. And it'll be something that you guys will see in practice. Again, there's a huge push for us to be able to bill directly under our own provider number because it is something that feels also good to us, and we should be able to be recognized for our worth that we bring to the table. Almost every encounter between you as an acute care NP and a patient will be associated with the payer. And so sometimes you're just stuck with their rules on how to get reimbursed for your pay. Medicare leads the way. If you guys will figure this out already, if you haven't, Medicare leads the way. So Blue Cross Blue Shield, United, all those things pretty much take after whatever Medicare does. So Medicare is a huge payer across the healthcare system in America. So once Medicare decides to do something, typically the private insurances will follow suit. So for Medicare reimbursement, office and non-hospital clinic setting can be a direct billing. So the acute care NP provides evaluation and management and submits a bill under your own NPI. But again, this is where the incident to billing provides coverage of services furnished incident to professional services of the physician. It gets messy. You have billers and coders and people in the hospital and all these things, and it gets very confusing for people. And then there's Medicare will question things based on the location, so inpatient, outpatient, or emergency. Billing depends on whether the acute care NP salary is listed on the hospital's Medicare cost report, and then also shared billing, incident to billing, all of these things. So when you get into practice, there's always going to be a learning curve to understand how this works, and you'll learn along the way. Critical care reimbursement has also been a challenge because those are charged according to time. So either the acute care NP or the physician, but only one may provide the initial 30 minutes of critical care time. So if you admit somebody to the ICU and you're in there for an hour and a half and your physician comes back by, it depends on a lot of things on who's going to bill for what. So mainly that I've had experience in is that where I worked as ICU or hospitalist part, I just got billed, or excuse me, I was paid a salary. I was not RVU based or production based that determined my salary. Some physicians, however, have revenue value unit based income. So how much they bill can directly impact their paycheck that they take home. So now you're in a situation where that physician, by George, is going to come in after you and see that patient and bill for it because they only eat, what they kill, so to speak. So they have to be able to come in and take that. So if only one of you can do it and your salary is guaranteed and their salary is dependent on billing, they're going to bill. That makes sense, right? The trouble with that is then when you sit back and you look at data of what role we bring and what we do and how we provide care, a lot of that comes from extraction of billing and coding. So it can be really difficult for you to justify or to show your value and your worth of what you've done when you're never able to quote unquote take billing credit for it. And so that can be a tricky thing when you're talking about research and outcomes for NPs, right? Because it's hard then to capture what we do and we don't do when there's not an easy billing or coding system that you can tease data from for billing and coding. Also, I got to tell you, it's really hard to keep up with Medicare and Medicaid. They change every 2 or 3 years. People have specializations in understanding billing and coding. So you'll get a new update from somebody. This is what the new 2024 says. And there's nuances and differences. And they took this out and they added this. And you got to say this. It can give you an eye twitch, and it's an ever-changing situation. And then here we talked a little bit about that we have to monitor our outcomes, etc. So, okay, that was a very fast, kind of quick and dirty attempt at getting in there and kind of pointing out what it's like to be an acute care NP and what that looks like for you guys, and how that's a little different than other APRNs, how it's a little different than the CNS, and just a little bit of discussion on what that might look like for you to chew on. Again, please shoot me any questions or concerns, and thank you for listening.